Thank you, sir. And I would like to welcome our state expert for ESAP webinar series, Dr. P. Srinivasulu. Sir is currently Professor and HOD of Department of Endocrinology, Kurnool Medical College. I welcome you, sir, for this evening.
Thank you, Doctor. Thank you very much.
And I welcome our team ESAP, Dr. M.V. Ramohan, sir, and Dr. K. Vamshi Krishna, sir, to join this meeting.
Hi, good evening, everyone.
Good evening, sir.
Hi.
Good evening, sir.
Hi.
Krishna, please go ahead with the case.
Yes, sir. And our case presenter, Dr. Lavanya Katakam, Madam is currently practicing in Guntur. I welcome Dr. Lavanya to go ahead with the case for today's 6th ESAP webinar series.
Thank you, Dr. Radhakrishna. So
Thank
you, ESAP, for giving me this opportunity. So I'll start my presentation. So am I visible? Is the screen visible? Slides?
Yes, madam.
Okay. So I have not seen a congenital hyperparathyroidism case. So in this platform, I wanted to share this, and also the primary pediatrician who has seen this case is also in this webinar. So we can discuss with her also. So I have seen this patient as a referral basis only. So the patient was already worked up by the time I have seen the case. So a 2-month, 20-year-old female child born out of third-degree consanguineous marriage, first in birth order, was brought with a complaint of loose stools since 21 days of life and vomiting since 1 month of age. And she had reduced urine output and failure to thrive. So patient was evaluated for these complaints at a other pediatrician. So they have done ultrasound abdomen where it was shown to have renal calculi and DJ stenting was done by the urologist. This case, antenatal history was uneventful and she was born at 39 weeks of gestation with birth weight of 2.8 kg and the baby cried immediately after birth. So at presentation to the hospital, the baby weight was 2.3 kg, length 51 centimeter and head circumference was 33 centimeter. Baby was sick, dehydrated, emaciated and tachypnea and tachycardia were noted. Abdomen was distended, but systemic examination was normal. On evaluation, total count was slightly elevated, 16,000. Normocytic, normochromic, no abnormal cells were seen on the peripheral smear. CRP was 2.7. Sodium was lower, 128 millimole per liter. Creatinine was normal with potassium normal. So SGOT, SGBT were slightly elevated, but proteins were low. Corrected calcium for this baby at the time of presentation was 8.82 milligram per deciliter. Magnesium was 1.6 and phosphorus was 4.34. Further evaluation of the 25-hydroxy-D, it was 32.4 nanogram per ml. Intact PTH was 568 picogram per ml. 125 dihydroxy vitamin D was also 88.3 picogram per ml. FT4 was lightly lower limit of normal and TSH was 4.15 microintonation units per ml. ABG showed normal blood gas analysis. Bicarb was also normal. PCO2 and PO2 were in the normal ranges. And urine electrolytes in the study, in this case, it was noted that calcium, the excretion, I have calculated the fractional excretion of calcium, it was 0.01 in this case. And so you showed certain proteinuria. So further, in the other further analysis, a newborn screening showed normal levels of acyl carnitines and normal levels of amino acids and other 17 OHP. All this newborn screening was normal. There were no abnormalities. In the X-ray abdomen, you can see the dilated bowel loops in this case, and ultrasound abdomen at the time of presentation to the other urologist showed bilateral non-obstructing soft renal calculi with enlarged right kidney and right hydroureteronephrosis secondary to large obstructive 2.6 centimeter mid-ureteric calculus was seen along the mid-ureter. And after DJ stenting, at the time of admission to this pediatrician, the ultrasound abdomen showed multiple renal calculi in both kidneys. Largest of size was 9 mm on the right side and 10 mm on the left side. DJ stenting was noted on the right side. 2D echo, small ascended cardiac congenital heart disease with the PDA open was seen with good biventricular function and no PAH, and IVC was collapsed in this case. So after my consultation, we have opted for, as the corrected calcium was also normal, creatine was normal. I had to think about this is a case of further whether there are any hyperplasia of the parathyroid glands. We have seen the system B scan. System B scan showed uptake in the suprathyroid focus, which was possibly parathyroid origin. So genetic analysis, it came after the baby was discharged. So genetic analysis, yeah, I think it is not visible. So is it visible? Hello?
Lavanya,
No,
you
madam,
just
it
read
is
out
a
the
little
report.
bit blurred.
You read out the report.
Yes, madam, it is visible.
Now you can see.
Yes, madam.
So in this baby, the genetic analysis came after the baby was discharged. So there were no significant or pathogenic likely related to nephrocalcinosis, hypocalciuric hypercalcemia, because we suspected inactivating calcium sensing receptor mutation. But there was homozygous likely pathogenic variant of DG81. So that is protein losing enteropathy type autosomal recessive homozygous. So they have noted in this report that this is the first time they have noted the DG81 report because it was present in early infancy, which is characterized by early onset chronic diarrhea, but not in a case of nephrocalcinosis. So many patient that is isolated nephrocalcinosis is not reported till date in literature, but many pediatric patients with intestinal failure showed increased echogensity and nephrocalcinosis. This was the report. That is diarrhea 7 protein losing enteropathy type. So the treatment which we did was the baby was adequately hydrated with frequent breast feeds. IV fluids were given, DNS according to the pediatrician protocol. Antiemetics were given. I have started this baby on cinacalcet because baby was 2.24 kg only. So we have consulted a endocrine surgeon. So after endocrine surgeon referral, they have given the mortality rate of around 50% for this baby. So we tried to think about increasing the general condition of the baby. So medical management of was opted because calcium was already corrected. Calcium was 8.8 only. So we have started at a lower dose of 0.3 gram per meter square per day. That is 3 mg per day was given for the baby. Because of low 54, I have started lower dose of 25 microgram half tablet daily. So the parents were given the option of total parathyroidectomy, but they were reluctant and wanted to continue the medical management. The baby was discharged prior to the report, genetic analysis report came. So after we consulted for the genetic analysis report, they have told that the baby succumbed to So the baby succumbed because of the poor general condition. So this is my case. So shall we, if anything which we have missed or anything which we have done, I want to ask the state and national experts to give your valuable inputs. Hello,
Hello.
Scroll back
Very
the slides
nicely
to the genetic
presented.
report, please.
sir.
Yeah.
Sir, కనబట్లేదు సార్. This is
Name
the
shift mutation.
sir
Upset.
DG81 mutation, sir.
The diarrhea protein losing enteropathy kada main ga.
Yes, sir. Yes, sir. So, but this patient also, they have no, the hyperpara cases I have seen inactivating calcium sensing receptor mutations. So, neonatal severe hyperparathyroidism also, this mutation is not there.
Do we have urine calcium anytime?
Done, sir. Urine calcium fractional excretion I have calculated. I'll show you, sir, once. Sir, this is the urine electrolyte report, sir. Urine calcium was 5.46 milligram per deciliter, spot 1. So calcium creatine ratio was 0.2. I have calculated fraction excretion of calcium. It was 0.01, sir.
0.01.
Yes, sir. But there was proteinuria also in the complete urine analysis after. Sir,
So this is actually gray zone. So what I can gather, Nagesh definitely would comment over it. And what we can gather is a case who presented with dehydration, who had a failure to thrive, and who had abdominal distension, and was found to have a relatively normal calcium, but phosphate
yes,
was on the lower side for a neonate
yes,
actually.
yes,
So that is intriguing. And the PTH was found to be on a higher side. Right.
yes, yes, sir.
So, do we have a maternal vitamin D or maternal status related to that? Though I know that the vitamin D of the baby is 32.4, but
Yes,
Nagesh will also be aware that we see many patients when the baby has high PTH, and that is because of vitamin D deficiency in the mother during the pregnancy. And I
sir.
presume that this might be done maybe within first 2 to 3 weeks, this PTH. Is it?
No, sir. We have repeated at the time of admission also. So previously also it was done before admission. It was in the 500 range. After 2 months, 20 days, the baby came, sir. At that time also it was more than 500, sir.
Thyroid was
2 times, sir.
No. Basically, the question here is one
Sir.
question we have to ask about this case is even if the mother has vitamin D deficiency, the PTH will not be so high.
Yes,
And the child is not going to present with this such a severe picture where there is nephrocalcinosis and renal calculi.
yes, sir.
But the mutation is actually not matching, right?
Yes, sir.
GNAT is
Mutation is
not
same.
matching. But probably the problem is with our genetics labs. There has to be a mutation. This has to be a congenital condition.
Yes,
But sometimes they don't do a proper sequencing. The sequencing and the exome sequencing, which is done in this particular commercial labs, is always not totally up to the mark.
yes, sir.
They don't do a deep analysis or they will not look at the complete gene. If
The
the child had
genetic
survived longer, probably
we could
tell
have
them in
repeated.
India, whenever we get the genetic reports, they'll be along these lines only.
Yes, sir.
It's a hit or a miss.
Yes,
It's only in the West that they look at promoter genes, and like Ashu was saying, if the mother has one gene and the father has a promoter gene, that
yes.
can explain this kind of a picture.
Okay.
I don't think this is where I think I'd like to slightly disagree with Ashu that mother's vitamin D status is important, but will not be responsible for such a severe clinical picture.
Yeah, exactly. You're right, Nagesh. So we are looking at a patient who is having renal calculi, and that is very early in the life, and maybe congenital also, because congenital means fetal also, because patient has soft calculi even at birth. So that means we are dealing with a case when there is hypercalciuria,
Yes,
because you cannot have the renal calculi such early unless patient is having hyperoxaluria or hypercalciuria. So we have to think of conditions which can cause hypercalciuria very early in the life. So in this context, I don't dig deep into the technician system EV scan, because that can
yes,
be
sir.
really false. And for practical purpose, we have seen cases where we have again coming to mother's vitamin D deficiency, and we have seen that patient, the neonate would have parathyroid hyperplasia because of mother vitamin D deficiency, and that
Yes,
can lead to the increased uptake on the parathyroid scan. So
yes,
I will not say that it is hyperpara per se, just looking at the parathyroid scan, because PTH levels are normal, sorry, high,
Yes,
and
sir.
but the calcium levels are relatively normal. So
Yes.
at PTS scan, okay, it has some limitations. So I don't know. But more important thing for me is hypercalciuria. So conditions causing hypercalciuria. One is hyperpara, but there are many other conditions which can cause hypercalciuria. So probably we have to think over that. And moreover, patient is having protein losing enteropathy. So we have to think of associations with that which is causing hypercalciuria.
Yes.
The protein losing enteropathy in this child is probably because of the GNAT mutation.
Yes.
Hmm.
DGAT mutation.
DGAT mutation can cause some
Yes,
amount of the entropathy.
protein.
You'll have to
Yes,
check
sir.
it out. Huh.
Okay, sir.
Probably this child has two conditions, one of which was because of the DGAT mutation, and the other one is essentially because of some other mutation which was not picked up.
Yes.
And Ashu, what Ashu has told is absolutely right in the fact that even in adults, sestamate scans are many times suspect. That's
Yes,
why we
sir.
go with other things like methionine and choline and obesity.
Yes, sir.
No, imagine doing a scan in a very young child. Such
Yes.
a young child, it is what you have seen in adenoma, hyperplasia is all subject to conjecture.
Okay, sir.
So to add to this discussion, another scenario, do we have any family history related to it? Like we don't see so-called hyperpara very early in men one also,
Yes, sir.
but usually they mention that men one usually have hyperpara around 5 to 8 years of age when we start screening if we have an index case and a mutation. So do we know anything about the family history related to
Father and father have already interacted, sir. So they have told that they did not have any medical history, anything relevant I have asked. So nothing, sir. But they were consanguineous, that's all, sir. There is no any relevant medical history in those.
Yeah, another disease that I could have think of is RTA, which can be associated with very early onset of hypercalciuria.
ABG we have
Though
done, sir.
ABG was normal.
Normal, sir.
The ABG was normal, but the
Sir.
fetus, the neonates, if you have urine,
Okay, sir.
this ability to just secrete ammonia is poor.
Okay,
And
sir.
sometimes we have to do the challenge test also, the
Okay, sir.
bicarb challenge test also. So actually, we are not sure about whether we have hypercalciuria or not. I'm not sure about hyperpara as a diagnosis in this whole
In
story.
this case. Okay, sir.
Yeah, and the
Yes.
cause of demise uh, is very difficult to discern. That because patient did not have hypercalcemia per se.
That's
So cause of demise, failure to thrive, dehydration, some urine concentrating ability defects in the kidney. So again,
okay.
it goes to RTA.
Okay,
So
sir.
difficult to say. Nagesh can definitely comment over it.
The connection, Ashu. What were you asking? Can you hear
Yes,
me?
urine concentrating defects and hypercalciuria and the cause of demise. That all the point does not just connect with each other.
Yes. There have to be two different conditions which are contributing to this picture, or some new condition about which we haven't known till date.
Sir, Dr. Lokeswari madam is there, sir. In this, Madam Lokeswari madam. Hello. Madam is the primary treating doctor for this baby, sir. So I have invited them to join also. So she can share some details if she is willing. Madam. Hello. Sir. She is not responding, sir. Sir, we'll continue with the discussions. Hello.
Yes, madam, please go ahead.
So PTH, primary hyperparathyroidism, is currently recognized as the third most common endocrine disorder in adults. So it is most commonly presented at the ages of 50 to 60 years. And the incidence of this primary hyperparathyroidism in adults is around 30 cases per 1 lakh population. And there is a female preponderance in the primary hyperparathyroidism in adults. Whereas in children, and that is congenital hyperparathyroidism. It is only presented in 2 to 5 per 1 lakh population, and there is no sex predilection. So, congenital hyperparathyroidism can be isolated or syndromic. So, isolated hyperparathyroidism, mostly this is neonatal severe primary hyperparathyroidism, is mostly caused by inactivating mutations of the calcium sensing receptor, and other hyperparathyroidism cases that is isolated are familial hypocalciuric hypercalcemia type 1 to 1-3, and syndromic cases like MEN1 syndrome 2A, and also hyperparathyroidism jaw tumor syndromes are also noted. So treatment options which we do are, that is early surgical intervention with subtotal parathyroidectomy. That is prior to 1980. So the cases reported were only 150. But after 1980s, there are more than 300 cases which are reported of congenital hyperparathyroidism. And that previously the mortality rates were more than 50%. But nowadays, after the advent of intravenous bisphosphonates, the mortality rates have come down, and recent case series reported no mortality also. And calcium emetics are also nowadays routinely used. That is, recent case series have demonstrated better outcomes with early screening, diagnosis, and treatment. Thank you for the opportunity, and I will stop my presentation. So if we can discuss. So
Thank you for the wonderful presentation, madam. Now we can take question and answers session.
Lavanya garu is a
Sir.
good case,
Sir.
but see how frequently are there? I mean, all the doctors who are attending this, I think we have not seen such cases actually.
Sir.
If there are, we can ask Nagesh because he's a pediatric endocrinologist, and anybody has seen such cases, then they can give some information on that.
Sir, with all due respect, I am an adult endocrinologist only. We see pediatrics for time pass. So basically, these kind of cases, usually more often than not, they will present only 99% of the cases who present with neonatal hyperpara will be calcium sensing receptor mutations only, who will present with calcium sensing receptor mutations. The other causes, other mutations like the GNAS2, there's some things even we have to read up about them because we don't see them routinely in our practice.
Yes.
It's almost like seeing these cases very rare. I don't know how many cases Ashu has seen, or I saw one probably a few years ago. They were all CSR. 1 or 2 cases were calcium sensing receptors only. Diagnosing it is very easy. The minute you do the urine calcium and creatinine ratio, you will know what is the diagnosis. The other ones are very rare. Even like Ashu was saying, autoimmune polyglandular will present, but they don't usually present in the neonatal period.
Yes.
Almost for all, this is something which is very new even for all of us.
Dr. Lavanya,
Sir.
what was the main the diagnosis sent for genetic analysis? While sending for genetic analysis,
For nephrocalcinosis, we have sent nephrocalcinosis.
when you return, it's we are suspecting calcium sensing receptor mutation.
Hyperparathyroidism and nephrocalcinosis
Okay.
were present. Sir, are there 2 questions are there in the chat box, sir? So
Yes.
from Dr. Nikhil Sanjeev. So respected faculties, thyroid function test in hyperparathyroid have shown discrepancies in adult patients also. Here also TSH is normal and free T4 was low. How to take this interference? And also another question, could DENTS explain the renal calculi and proteinuria? Sir, I have no answer for this.
Can I take the first one?
Sir, please.
Yeah,
Sir.
the first one is very much well taken. I don't give a lot of importance to free T4 in a neonate when the TSH is
sir.
normal and free T4 is a bit on the lower side, especially in somebody who's very sick. It can always be an NTIS, non-thyroidal illness syndrome, or like I said, interference because of the hyperparathyroidism. I would have preferred waiting and watching in this case.
Okay.
Because, and as such, our free T4 assays are very subjective in a child of this particular age group.
Okay.
Free T4, as such, free T4 is not very good. In India and in a neonatal age group, free T4 can be the only reason why we do free T4 or why we give importance to free T4 is that we don't want to miss out a case of central hypothyroidism.
Yes.
And a child presenting with congenital hyperpara and central hypothyroidism will be too much of a coincidence.
Yes.
So I don't think it is a major issue.
Okay.
So that is one. The second thing, dents usually does not present in this particular age group.
Okay, sir.
It will present only later on in the childhood. Presentation with dents can be very similar, but again, if you want to diagnose that it's a case of dents, the only option you have is a genetic analysis, and genetic analysis has not shown any changes or any problems in the OCRL1 gene. It's either CLCN5 or OCRL1, either of the two genes. Both of them have not shown this kind of a picture. A renal tubular acidosis like kind of picture, renal phosphorus loss, bicarbonate loss, and acidosis like picture can be seen as somewhat similar to Fanconi like picture in dents. And there will be a strong family history. Most of the cases, I've seen a few cases, most of them will have a family history of nephrocalcinosis. Was such a history seen in this child?
No, sir.
Any
Family history not relevant, sir. We have asked.
family history. That is one thing, and somebody presenting with a neonatal, and it will always have to be a homozygous mutation, consanguineous marriage or rare homozygous mutation. So it would have been picked up. In all probability, dents would have been picked up, even though a few dents have been reported in neonates.
Okay, sir.
But the genetic analysis has not shown us anything. In
Yes.
that scenario, I don't know how far we can. And interpreting renal tubular disorders in a neonate can be very difficult in the setting of somebody who is very sick.
Yes.
The nephrocalcinosis itself can cause tubular damage and cause proteinuria and a lot of other clinical other features, which might not be very conducive to the clinic diagnostic
Yes.
picture. But whatever it is a very difficult. Say that I don't have an answer to this case. You did whatever you could, the best possible thing you could. Maybe a parathyroidectomy would definitely have saved the child. Cinacalcet will not help in such a bad child. Did you try plasmapheresis?
No, sir. Plasmapheresis not done, sir.
No, but again, or in
But I didn't, because corrected calcium at that time was normal, sir. So I also suspected any renal impairment.
Yeah.
So the baby is going. So we didn't go for any other. We have sent for endocrine surgeon opinion. But sir also they gave 50-50 chance, and the parents were already, they were roaming from hospital to hospital for the past 1 month. So they wanted to wait, and they wanted to see whether this medical management might improve the baby's condition, and then they wanted to proceed, sir. But within 1 week she is expired.
As such, mortality this is 50%.
Sir, sir?
Mortality is around 50%.
Yes, sir. Yes, sir.
Even in the best managed ones, even with hypopara, this is 50%.
Yes.
Lavanya garu, baby was given only 1 week treatment.
No, sir. Baby initially by the 20 days of life itself, they have gone to one pediatrician, sir. So they have picked up nephrocalcinosis, and then to a urologist. Pediatric endo in Guntur, one doctor has seen. So from there, the baby's general condition was not improving. So they came to this doctor, sir.
She was on, the baby was on Cinacalcet.
Treatment. No, sir. Cinacalcet only 1 week, sir. That's all.
Yeah, that's.
I have seen in the last stages, sir. So that's why I am asking for opinion whether we have missed anything. So there is another question in the chat box. Could this clinical picture failure to thrive, hypophosphatemia, elevated PTH, normal calcium be an early manifestation of IPEX syndrome, sir? Srinagesh, sir. Sir, Srinagesh, sir.
There is a question in the chat box. Could this clinical picture of failure to thrive, hypophosphatemia, elevated PTH, and normal calcium, nephrocalcinosis, and protein-losing enteropathy be an early manifestation of IPEX syndrome? And how does IPEX typically present in neonates or early infancy? This question is open to our experts. I would like to give few insights about this question, if you permit.
Please, sir. Please,
Yes.
please continue.
Coming to typical IPEX in neonates and infants, the core features will be severe diarrhea, protein-losing enteropathy, failure to thrive, eczema, and other autoimmune diseases like type 1 diabetes, and onset will be within the first few weeks to months of life. And whereas neonatal diabetes or diarrhea can appear in first month in severe cases.
Sir.
And whereas in coming to the lab findings, there will be hypoalbuminemia and hyperglycemia if there is type 1 diabetes, and autoantibodies like anti-androcyte antibodies will be positive in these cases. And there will not will nephrocalcinosis is rare in this IPEX syndrome. Coming to this case, it matches IPEX in terms of failure to thrive and protein-losing enteropathy, but it does not match IPEX in terms of hypophosphatemia and elevated PTH and nephrocalcinosis, as it suggests a renal or metabolic issue. And normal calcium with the elevated PTH also points to secondary hyperparathyroidism,
Hyperthyroidism.
possibly from vitamin D deficiency or renal wasting, which is not a primary feature of IPEX.
Yes.
And respected doctors, if any other questions regarding this case discussion are open. Now, I would like to invite our team ESAP, Dr. M.N. Rammohan sir and Dr. Vamsi Krishna sir to give their valuable insights about this case.
Hello. Hello. Hello.
Madam, I think there are no further
Questions.
questions.
Thank you. Thank you for sharing all your insights.
Thank you, madam. And thank you everyone for participating in this webinar series. And I am glad you have enjoyed this webinar, ESAP webinar series 6. And thank you for attending. And I hope you found the insights valuable and stay tuned for more exciting sessions in the future. Thank you,
Thank you,
everyone.
Dr. Lavanya Garu, for presenting an excellent case, which we have not seen. I think we'll be from now onwards, we'll be more vigilant about that.
Thank you, sir. Thank you for sharing your insights, sir.
Thank you for such an excellent case.
Thank you, Srinagesh, sir, and thank you, Ashu, sir, for sharing your insights, sir. So we'll be vigilant in the next future also, sir. Thank you, sir.
And one more note regarding our guest of honor, Dr. Ashu Rastogi. Sir is competing for Joint Secretary post in ESI to inform you all. Thank you very much.
Thank you, sir. Best wishes, Ashu, sir.
Thank you, everyone. We'll wind up this session. And